Hi, friend. I'm Dr. K from nursingacademics.com. This is your comprehensive master lecture on anticoagulation, the only lesson you'll need to master this topic for your exams. Before we dive in, let's invite the parasympathetic. Take one slow breath and settle in. We're going from zero to exam ready, together. Remember, perfusion is the delivery of the payload, oxygen, glucose, amino acids, and electrolytes to the cells. It is the foundation of clinical learning, powered by the pump, the pipes, and the pressure. Today we're meeting the hepatocyte and the platelet, two factories working together to prevent bleeding. Their mandate: manufacture clotting factors and form stable clots. But no factory runs without fuel. The hepatocyte needs ATP to synthesize clotting proteins. ATP only arrives when perfusion is working. Now let's meet the platelet. This cell fragment's mandate is simpler. When a blood vessel breaks, rush to the site and plug the hole. Platelets don't wait for clotting factors. They clump together immediately, forming a temporary plug. This is called primary hemostasis. But the platelet plug is fragile. It needs reinforcement. That's where the clotting cascade comes in. The hepatocyte's clotting factors arrive to stabilize it. The clotting cascade is an assembly line. Factor activates factor, ending with fibrin threads that lock the platelet plug in place. Factors 2, 7, 9, and X all require vitamin K. Think of vitamin K as the final tool the factory needs to ship a finished product. But here's the catch. Some clotting factors need vitamin K to finish assembly. Without vitamin K, the hepatocyte can't complete the job. Now that we know how clots form, let's meet the drugs we use to slow that process down. We call these anticoagulants. They don't thin the blood, they break the assembly line. This is where anticoagulant drugs work. Each drug targets a different step in the cascade, breaking the assembly line at a specific point. Heparin works fast. It activates antithrombin 3, a molecule that blocks factors 2A and XA. The cascade stops in seconds. Because heparin works on circulating factors, it acts immediately. This is why we use it in emergencies like pulmonary embolism or acute MI. Then there's enoxaparin, low molecular weight heparin. It's more predictable than standard heparin and is usually given as a subcutaneous injection in the abdomen. Exam alert! For enoxaparin, teach patients to love their handles. Inject in the abdomen. Never expel the air bubble from the pre-filled syringe, and never rub the injection site. PTT measures the intrinsic pathway. We use it to monitor heparin. Therapeutic PTT is 1.5 to 2 times normal. If heparin caused the bleeding, we give protamine sulfate. Protamine binds to heparin and neutralizes it immediately. The antidote is fast. This is where warfarin works. Warfarin blocks vitamin K inside the hepatite. No vitamin K means no finished clotting factors. Warfarin enters the hepatocyte and occupies the vitamin K receptor. The cell can't activate factors 2, 7, 9, or X. Production stops. Warfarin works slowly. It takes 3 to 5 days because it doesn't block existing factors. It prevents the hepatocyte from making new ones. INR measures the extrinsic pathway. We use it to monitor warfarin. Therapeutic INR is usually 2 to 3, sometimes higher for mechanical heart valves. If warfarin caused the bleeding, we give vitamin K. The hepatocyte can now finish making clotting factors, but this takes hours to work. Exam alert! Patients on warfarin don't need to avoid vitamin K. They must be consistent. Don't suddenly start or stop eating green leafy vegetables, or your INR will crash. DUACs, direct oral anticoagulants, work differently. They directly block one factor, either XA or thrombin. Faster onset than warfarin, more predictable dosing. DUACs don't need routine monitoring. Their effect is predictable at standard doses. But if bleeding occurs, we have limited ways to measure their activity. DUAC reversal is harder. Idarucizumab reverses dabigatran, and Exanet alpha reverses factor XA inhibitors. These are expensive and not always available. Now, the most important part for your practice: how do we keep the patient safe? Regardless of the drug, the biggest risk is always the same: bleeding. What happens if anticoagulation goes too far? The hepatocyte can't make clotting factors, the cascade fails, and the patient bleeds. Bleeding cues: bruising without trauma, blood in urine or stool, gum bleeding, nosebleeds, or falling hemoglobin. Keep a close watch, because these are clinical SNS alarms. When bleeding starts, the SNS fires. Heart rate rises to pump faster, trying to maintain perfusion despite blood loss. Tachycardia is the alarm bell. For life-threatening warfarin bleeding, we give fresh frozen plasma or prothrombin complex concentrate. These contain ready-made clotting factors, immediate effect. Bleeding precautions are critical. Teach patients to use soft toothbrushes, avoid razors, report bruising, and avoid NSAIDs and aspirin. NSAIDs and aspirin block platelet aggregation. If you combine them with anticoagulants, you disable both the platelet plug and the clotting cascade. Finally, let's connect this back to our foundation. Every part of the clotting factory depends on perfusion, the delivery of oxygen, glucose, and amino acids. Now let's connect this to perfusion, the delivery of oxygen, glucose, and amino acids to the hepatocyte. If the patient can't breathe, oxygen doesn't reach the hepatocyte. No oxygen means no ATP. No ATP means the cell can't power protein synthesis. If the patient can't perfuse, nothing reaches the hepatocyte. No glucose, no oxygen, no amino acids, no vitamin K. The factory shuts down completely. This is why liver failure causes bleeding. The hepatocyte can't make clotting factors. The cascade fails. The patient bruises, bleeds, crashes. When you see prolonged PT and INR in a liver failure patient, that's not warfarin, that's a dying hepatocyte unable to fulfill its mandate. And when that factory fails, bleeding starts. That's why nurses watch A, B, C, D, E, F, G, airway, breathing, circulation, including vitals and skin, disability, electrolytes or exposure, fluids, and glucose. Everything else is downstream of perfusion, the ultimate goal of the pump, pipes, and pressure. Retention quizzes will help you lock this in. Your job right now is to build a clean mental picture: what's supposed to happen and what breaks it. As you move through this tutorial, slow down. Understand first. The retention quizzes will help you remember the details. Stay with it. You don't need to rush. You're building understanding that will travel with you. You can do this. I'm Dr. K at nursingacademics.com. You're ready. Let's get started.